we have about 10 minutes for rebuttals and questions. I have a couple technical questions. When performing the TCAR, is the stent a specific stent for that procedure, or do you have the option of any kind of stent, or what's the technical aspects of that?
So it is a self-expanding stent. It's a proprietary stent made by the company Silk Road Medical. It's called an en route stent. And there are various stents available for carotid stenting, but for TCAR they prefer their own. But typically it's the same, predominantly it's the same structure. There are other stents which are tapered, which conform to the internal carotid a little better, but we've seen that this is a soft open cell which accommodates and then is compliant, and so it should not cause any problems in the ICA.
And then this is for both of you. I think you have the advantage of having our colleague Joel Karami often monitoring cases, giving you real-time information about flow. This is a transcranial Doppler, and they can report to you all that there are hits, which are tiny little emboli possibly, or that there's a hemodynamic issue. Can you share with us, between endarterectomy and TCAR, what, if anything, have you learned about the reperfusion, the perfusion, the intraoperative issues?
I can begin with that. It's a great modality to have while you're doing an operation, particularly for endarterectomy. It can help guide us if we need to shunt. We can see if the flow rates in the MCAs drop below 50%, and it gives us a really good real-time understanding of the flow in the brain. I don't believe that we see that many hits when you're completely clamped. I haven't seen any in my experience with that. So I still feel that when you're actually clamping the internal carotid, you're very protected from emboli from that side. But of course, when you're unclamping, though, you're always risking any of the debris or anything going up there. And of course, I think the main downside is if there's any sort of injury to the internal carotid, dissections, thrombus formation there, that can lead to it. So it's all afterwards. But during, I feel you're very protected for strokes during. But obviously, as we've seen with the literature out there, there is still stroke risk.
Now, I would say TCD is the single most sensitive and specific modality for intraoperative monitoring for us, at least. And it is so beautiful to see a waveform that is blunted and then goes up to normal once you revascularize. That's number one. It's also very disheartening to see emboli going up there. But then not every embolus is a significant embolus, because it could be particulate matter which autolyses. The main thing we look for is there a drop in the MCA waveform after we revascularize? If there is one, there is definitely a significant embolus upstream. And hyperemia, the question Dr. Volpe you asked, is also clearly seen on TCD. As soon as you unclamp and you go up, if the pressure is high, we see that the brain matter is now getting 120%, 140% of what was at baseline. And then we can titrate that, and we see real time the auto-regulation that happens. So it is a beautiful modality that we use and we try to use.
But between the two techniques, is there any, do you more often see, say, hyperemia with endarterectomy or with TCAR, or is it about the same?
I think it depends on contralateral circulation and the degree of stenosis on this side. So if the contralateral circulation is wide open, typically the auto-regulation is pretty good. But if the other side is also heavily stenosed, this was stenosed, and you open it up, that hyperemia can sometimes be obvious on this side. It probably will auto-regulate, but initial hyperemia is more with any modality, I think, both TCAR or carotid stenting.
Do we have questions, Dr. Garg?
I have a question for both of you guys. For high-risk patients, when you do TCAR or CA, is there any role of like a cerebral angiogram, like post-procedure, or like kind of making sure that 3 minutes that we want to save? Have you had cases where you think that there is a need for a cerebral angiogram right after finishing a procedure?
After procedure, in general, I think there's a role for carotid angiograms if we're looking at preoperatively. If you have different imaging modalities that tell you a different story, say the carotid duplex shows less than 50%, but your CT shows a high-grade lesion, then I would do that. For postoperative, if, say, carotid endarterectomy, we typically, if we don't have TCD, if we just have a Doppler signal, and Doppler is a high-resistance signal, and you're worried about occlusion distally, saying there's high-resistance waveforms, or even audible high resistance, then you'd be concerned. Say your other modalities, if you have cerebral oximetry or EEG monitoring, and that's all looking like lower flow than you expect, then yeah, you could access and do a cerebral angiogram to identify if you have any problems with the flow distally?
I'll be honest, I'm like, see no evil, hear no evil. So unless there is an indication, I don't do intraoperative cerebral angiograms. And I think but jokes apart, with the advent, with use of TCD, I think we are comfortable to say that once we reperfuse and the waveforms look good, or obviously better than before, then we don't typically do a completion angio. But there is definitely a role, but with the tools that we have, we've not found the need to do it every single time.
So I'll wrap up by just saying, did I hear correctly that our 80-year-old, or rather our 70-year-old with 80% asymptomatic carotid stenosis is a candidate for TCAR?
Yes.
And is a candidate for endarterectomy?
Yes.
I would say we have to look at the holistic picture. I would want to look at a CT to see what the kind of features of the plaque is. Is it has some soft thrombus involved, or is it all calcium? Are the other cerebral vessels stenotic? The contralateral internal, the vertebrals, are the vertebrals included? So if the other 4 or 3 arteries are stenotic, then I'd be more inclined to offer it. If they're wide open and patent and she's asymptomatic, I might actually just monitor her.
Yeah, I think that is a well-received response in this audience. But I would say that if you do operate, it sounds like your risk is 1.4% with both. So that's the maybe the take-home point is
anything but transfemoral.
I didn't say that. Well, thank you all both, and we'll take a.
I think Dr. Gadia, do you have a question?
Oh, sorry.
I think answered it, but we have the ongoing CREST-2 study, going back to the question of the asymptomatic, severe carotid stenosis, which I think at this juncture the right answer is actually to offer that clinical trial because we don't know what the right answer is, revascularization, regardless of what the technique is and what the risk comes. Do you know, Dr. Bavari, since you're leading the field in TCAR, whether that's going to be some component of CREST-2, some modification or an amendment? Or
the
anything?
actual procedure itself?
Yeah.
I don't think so. As far as I know, no, it's not part of the CREST-2 surgical intervention.
And I think, Dr. Chu, you're going to share with us?
Yeah, it is not part of CREST-2, but there is a movement afoot for CREST-3 to evaluate TCAR. And I'm just going to take maybe a slight issue with, a comment about superiority of any procedure that is based on observational studies and not controlled clinical trials. So I would be cautious with that. One of the big, sort of landmarks with carotid endarterectomy is it's almost certainly the best studied surgical procedure with respect to, the evidence base of randomized clinical trials. It's been studied over and over again in multi-center randomized clinical trials. And although TCAR certainly looks promising and deserves to be studied further, we hope that will be the role of CREST-3.
Thank you. And with that, we have a brief break to switch over to our next session.